A study published just last year in the Lancet Diabetes and Endocrinology revealed something that stunned even veteran researchers. Something that changes everything we thought we understood about why blood sugar won't come down in people over 60. And here's the part that should make you angry. This discovery wasn't some obscure finding buried in academic journals. This came from Newcastle University in England, from Professor Roy Taylor, one of the most respected diabetes researchers in the world. His team has been publishing this evidence for over a decade now. Yet most people fighting high blood sugar have never heard what I'm about to tell you. I'm Dr. Elizabeth Blackwell, and after 7 years of practicing medicine and staying current with the latest research, I need to share something with you today that could fundamentally change how you think about your blood sugar, and why it's not coming down despite everything you've tried. Because if you're over 60 and you've been cutting carbs, watching your sugar, taking your Metformin exactly as prescribed, and still waking up to fasting blood sugar numbers in the 140s, 150s, or higher, the problem might not be what you're eating. The problem might be what's blocking your body from using the insulin you're already making. And by the end of this video, you're going to understand exactly what that barrier is, why cutting carbs alone will never fix it, and the precise research-backed strategy that has helped people achieve something remarkable. Something the medical establishment told them was impossible. Remission. But here's what I need you to understand first. Because without this context, you could actually make things worse. Let me tell you about Howard. Howard was 68 years old, retired postal worker. He'd been diagnosed with type 2 diabetes 8 years earlier. And Howard did everything right. He followed the low-carb diet his doctor recommended. He took his Metformin faithfully twice a day, right on schedule. He even started walking 3 miles every morning, rain or shine. His wife Ellen would joke that he'd become the most disciplined man on their street. But every morning, when Howard pricked his finger and watched that little number appear on his glucose meter, 148, 156, sometimes 162, his doctor kept increasing his medication. First it was 1 Metformin, then 2, then they added another drug. Still, the numbers crept upward. Some people are just resistant. His doctor told him during a rushed 15-minute appointment, "Your body doesn't respond to insulin the way it should. We may need to start you on injections." Howard went home that day feeling something he hadn't felt since his diagnosis: hopelessness. He was doing everything right, and it wasn't working. His body had betrayed him. But here's what Howard's doctor never explained to him, what most doctors simply don't have time to explain in their packed schedules. Howard's insulin was working. His pancreas was actually pumping out more insulin than most people his age. The problem wasn't the key. The problem was the lock. Let me share something that researchers have now confirmed in study after study. And once you understand this, everything else will make sense. Imagine for a moment that insulin is a key. It's designed to unlock the doors of your cells so that glucose, that sugar floating in your bloodstream, can get inside where it's actually needed. This is how your body is supposed to work. You eat. Glucose enters your blood. Your pancreas releases insulin. Insulin unlocks the cell doors. Glucose flows inside. Blood sugar comes down. Simple. But what happens if someone takes that lock and stuffs it full of chewing gum? The key won't turn. No matter how perfect that key is. No matter how many copies of that key you make. The lock is jammed. In 2011, Professor Roy Taylor at Newcastle University in England published research showing exactly what was jamming the locks in people with type 2 diabetes. And it wasn't carbs. It wasn't even sugar itself. It was fat. But not the fat most people think about. Not the fat under your skin. Not even belly fat. Invisible fat. Microscopic droplets of fat inside your muscle cells, inside your liver cells, and inside your pancreas. Scientists call this ectopic fat from a Greek word meaning out of place. Fat where fat was never supposed to be. And when this hidden fat accumulates inside the very cells that are supposed to respond to insulin, those cells become deaf, resistant, locked. Your pancreas screams louder by making more insulin. But the cells can't hear it anymore. The locks are jammed. Now here's where it gets interesting, and where your frustration might finally make sense. Taylor called his discovery the twin cycle hypothesis, because there are two vicious cycles happening at once, and they feed each other. Cycle 1 happens in your liver. When you eat more calories than your body can burn, even if those calories come from healthy foods, your liver starts converting the excess into fat. A little at first, but over years, that fat builds up inside your liver cells. A 2021 study in the Journal of Internal Medicine showed that people with type 2 diabetes often have liver fat content of 15% or higher. Normal should be under 5%. That fat-stuffed liver becomes resistant to insulin's message. And here's what happens next. Normally, insulin tells your liver to stop releasing stored glucose into your bloodstream between meals. But a fatty, resistant liver ignores that signal. It just keeps pumping out glucose. All day, all night. That's why your fasting blood sugar is high even when you haven't eaten anything. Your liver is dumping sugar while you sleep. Cycle 2 happens in your pancreas. That fatty liver starts exporting its excess fat into your bloodstream as triglycerides. These triglycerides flood your whole body, including your pancreas. And those insulin-producing beta cells? They start drowning in fat. A 2013 paper in Diabetes Care showed that chronic exposure to fatty acids literally causes beta cells to malfunction. They can't release insulin properly anymore in response to meals. So now you have a double problem. Your liver ignores insulin and dumps sugar. Your pancreas can't release insulin properly when you eat. The two cycles spin faster and faster, each one making the other worse. And cutting carbs? It helps a little. But it doesn't fix the underlying jam in the lock. That fat is still there. Those cycles keep spinning. Comment yes below if this is starting to explain what you've been experiencing, because I want to know how many of you have been fighting this invisible enemy without even knowing it existed. Now here's what made Taylor's research truly revolutionary. His team didn't just identify the problem. They proved it could be reversed. In his Counterpoint Study, published in Diabetologia in 2011, Taylor took 11 people with type 2 diabetes and put them on a carefully designed low-calorie protocol for 8 weeks. And within 7 days, their fasting blood glucose started returning to normal. Not months, not years, days. The participants lost an average of 15 kilograms, but more importantly, the MRI scans showed exactly what was happening inside their bodies. The fat in their livers dropped dramatically. Their livers started responding to insulin again. They stopped dumping glucose. Over the following weeks, the fat in their pancreas decreased too. And as it did, those beta cells that had been drowning in fat, they started working again. First phase insulin response, which had been essentially absent, gradually returned. Taylor's team wrote that fasting blood glucose normalized within 7 days and beta cell function returned close to normal over 8 weeks. They called it reversal of the processes underpinning diabetes. Now I need to be very clear about language here because medical precision matters. This is not a cure. The American Diabetes Association defines remission as maintaining blood glucose below the diabetes threshold for at least 3 months without taking glucose-lowering medication. And that's what these studies showed was possible. Remission. The diabetes can be put into what I call sleeping mode. But if the original behaviors return, if the liver and pancreas fill back up with fat, the diabetes wakes up again. This information is designed to help you have a more informed conversation with your doctor. This does not replace their guidance. We'll talk about exactly how to approach that conversation in a few minutes. But first, I need to address something critical. Something that explains why this works for some people and doesn't work for others. And it has nothing to do with willpower or discipline. Let me tell you about 2 patients. I'll call them Margaret and Joseph. Margaret was 71 years old. She'd been diagnosed with type 2 diabetes just 2 years earlier. Her A1C was 7.4%. She carried about 30 extra pounds, mostly around her midsection. Joseph was 69. He'd had diabetes for 14 years. His A1C was 8.9%. He was actually thinner than Margaret, but his diabetes was far more advanced. Both of them worked with their healthcare teams to try Taylor's approach. Both lost significant weight. Margaret's blood sugar normalized within weeks. After 3 months, Her doctor was able to discontinue her metformin entirely. Her A1C dropped to 5.8%. By clinical definition, she achieved remission. Joseph didn't. His blood sugar improved. His liver fat dropped. He lost weight. But his numbers never crossed back into the normal range. He still needed medication. Why? Taylor's research revealed the answer. And it comes down to something called beta cell recovery. In a 2018 study published in Cell Metabolism, Taylor's team showed that remission of human type 2 diabetes requires decrease in liver and pancreas fat content, but is dependent upon capacity for beta cell recovery. In other words, those insulin-producing cells in your pancreas need to still be functional enough to bounce back once you remove the fat that's been poisoning them. And the longer you've had diabetes, the more likely those cells have been damaged beyond their ability to fully recover. The Counterpoint Study found that people diagnosed within the first 10 years had a very good chance of reversing their diabetes. But after 10 years, the chances dropped significantly. This doesn't mean it's not worth trying. Even Joseph, who didn't achieve full remission, still benefited enormously. His blood sugar was lower. He needed less medication. His risk of complications decreased. But it does mean that if you're watching this and you've had diabetes for 3 years, 5 years, 7 years, time matters. Every day you wait, those beta cells face more toxic stress. There's urgency here. Real urgency. Now I want to give you something valuable. Right now. No withholding. Taylor's research introduced a concept that might be the most important thing I share with you today. He calls it your personal fat threshold. And this explains something that has confused doctors for decades. Why do some people develop type 2 diabetes at a BMI of 25, while others with a BMI of 40 never develop it at all? The answer isn't about how much total body fat you carry. It's about whether you've exceeded your personal threshold for how much fat your body can safely store under the skin. Think of your subcutaneous fat, the fat under your skin, as a safe parking lot. It's designed to hold excess energy. And in that parking lot, fat is relatively harmless. But everyone's parking lot is a different size. Some people have a huge parking lot. They can carry a lot of fat without any problems. Others have a small parking lot. They overflow quickly. And when your parking lot fills up, that's when the overflow starts parking in dangerous places. Your liver, your muscles, your pancreas. A 2023 study in Clinical Science tested this hypothesis in people who had type 2 diabetes but were not overweight. Their BMI was under 27. By traditional standards, they shouldn't even have had diabetes. But they did. And when they lost just 6.5% of their body weight, 70% of them achieved remission. That's not a lot of weight. For someone weighing 160 pounds, that's only about 10 pounds. These people had exceeded their personal fat threshold even at a normal weight. And once they dipped back below it, their diabetes went into remission. This is why I'm telling you, forget the BMI charts. Forget what should be enough weight loss. The question is, have you exceeded your threshold? And can you get back below it? Comment personal threshold if this concept is changing how you think about your own situation. I want to see how many of you are having that light bulb moment right now. Now, I need to address something critical before we go any further. You might be thinking, okay, Dr. Blackwell, I'll just start eating very little. I'll do a crash diet. I'll empty out that liver fat as fast as possible. Please, do not do this. Because there are real dangers here. And if you're over 60, if you're on diabetes medication, if you have other health conditions, doing this wrong could genuinely hurt you. First, there's hypoglycemia. If you're taking metformin, or especially if you're on sulfonylureas or insulin, and you suddenly drop your calorie intake dramatically without medical supervision, your blood sugar could crash dangerously low. A 2019 review in the Lancet Diabetes and Endocrinology noted that in the direct trial, Taylor's team actually withdrew all diabetes and blood pressure medications at the start of the intervention, with careful monitoring. Precisely because they knew blood sugar would drop and patients could become over-medicated very quickly. This is not something to do on your own. Second, rapid weight loss carries its own risks. The National Institute of Diabetes and Digestive and Kidney Diseases warns that very low-calorie diets can increase the risk of gallstones. A 2013 study in the International Journal of Obesity found that rapid weight loss is a commonly described adverse event of very low-calorie diets, with gallstone formation affecting a significant percentage of participants. The risk increases when you lose weight faster than about 1.5 kilograms per week or when your diet contains almost no fat. Modern supervised protocols include small amounts of fat specifically to prevent this. Third, for seniors over 60, there's the risk of muscle loss. Your body doesn't just burn fat when you restrict calories. It can also break down muscle. And as we age, preserving muscle becomes critically important for balance, for independence, for bone health. This is why I'm telling you, this approach needs to be done under medical supervision. The direct trial wasn't a crash diet people did at home. It was a structured intervention delivered in primary care practices, with trained nurses and dietitians, with regular monitoring, with a careful reintroduction phase, and with long-term support. Who should not try this approach without very careful medical supervision? Frail seniors with a low BMI who don't have much weight to lose. Anyone with a history of eating disorders. Anyone with type 1 diabetes, which is a completely different condition. Anyone with kidney disease, liver disease, or other serious medical conditions. Anyone currently on insulin or sulfonylureas, unless their doctor specifically adjusts or stops these medications first. This information is designed to help you have an informed conversation with your healthcare provider. It is not permission to dramatically change your diet on your own. So how do you take action on this information safely? Let me walk you through what the research actually shows works. The direct trial, published in The Lancet in 2018, was the landmark study that proved this approach works in real-world primary care settings. It involved 298 people across 49 primary care practices in Scotland and England. At 12 months, 46% of the intervention group achieved remission, compared to just 4% in the control group. And the remission rate was directly tied to weight loss. Among those who lost at least 15 kilograms, 86% achieved remission. Here's what the intervention actually looked like. Phase 1 was total diet replacement for 12 to 20 weeks. Participants consumed a carefully formulated liquid diet of about 850 calories per day. This was not starvation. It was precisely designed to be nutritionally complete while creating the calorie deficit needed to mobilize that dangerous liver and pancreas fat. Phase 2 was stepped food reintroduction over 2 to 8 weeks. You can't stay on liquid formula forever. This phase carefully transitioned people back to real food while teaching them portion control and healthy eating patterns. Phase 3 was structured support for long-term weight maintenance. Because here's what the 5-year follow-up data showed, maintaining the weight loss was the hard part. Those who regained weight often saw their diabetes return. Now you might be thinking, Dr. Blackwell, I can't do a liquid diet for 20 weeks. And you don't necessarily have to. Other research has shown that various approaches can reduce liver fat and potentially achieve remission, including low-carbohydrate diets that create calorie deficits, time-restricted eating patterns, very low-calorie food-based diets rather than liquid formulas. Even standard calorie restriction can work if sustained long enough. The key isn't the specific method. The key is creating enough of a calorie deficit for long enough to mobilize that ectopic fat. But the rate of fat loss from the liver seems to matter. Taylor's research showed that the rapid initial reduction in liver fat was what triggered the quick improvement in fasting blood glucose within those first 7 days. Here's your action plan. And I want you to write this down. Step 1. Request a liver fat assessment. Ask your doctor about getting your liver fat measured. An ultrasound can detect fatty liver, though it's not the most precise. FibroScan is better. MRI is the gold standard, but usually reserved for research. Even without fancy imaging, elevated liver enzymes on a basic blood test, particularly ALT, often indicate fatty liver. Taylor's research noted that during the 18 months prior to diabetes diagnosis, serum ALT rises steadily, likely reflecting the steadily increasing burden of fat within liver cells. Step 2. Have the conversation about remission. Bring up the direct trial. Tell your doctor you've learned about the twin cycle hypothesis. Ask whether you might be a candidate for a medically supervised weight loss program aimed at remission. Here's exactly what to say. I've been reading about research from Newcastle University showing that type 2 diabetes can be put into remission through significant weight loss. I'd like to discuss whether this approach might work for me and how we could do it safely given my medications. Some doctors may not be familiar with this research. That's not their fault. Medical guidelines update slowly, and doctors are incredibly busy. But the NHS in England has now launched a national type 2 diabetes path to remission program based specifically on this evidence. The science is solid. Step 3. Get your medications adjusted before starting. If your doctor agrees this approach might work for you, they need to adjust or stop your diabetes medications first. Otherwise, as your blood sugar drops from the diet, you could become dangerously overmedicated. This is non-negotiable. Do not start a very low-calorie diet while still taking your full diabetes medication dose. Step 4. Consider working with a registered dietitian. A dietitian can help you design an approach that works for your preferences, your lifestyle, your other health conditions. They can monitor your progress. They can help you through the reintroduction phase. Step 5. Prepare for the long game. The direct 5-year follow-up data, published in The Lancet Diabetes and Endocrinology in 2024, showed that maintaining weight loss and staying in remission can be challenging. Some participants regained weight. Some fell out of remission. But those who maintained significant weight loss maintained their remission. Among those who kept off at least 10 kilograms at 2 years, 81% remained in remission. The intervention doesn't end when the diet ends. You need a long-term plan for weight maintenance. This is where community support, continued contact with healthcare providers, and having strategies for preventing weight regain become essential. Let me tell you about Gloria. Gloria was 66 when she was diagnosed with type 2 diabetes. Her A1C was 7.2%. Her fasting glucose was running in the 150s. Her doctor put her on Metformin. But Gloria had read about Taylor's research. She brought it to her next appointment. Her doctor, initially skeptical, agreed to supervise a trial. Under medical guidance, Gloria's Metformin was reduced as she began a carefully designed low-calorie protocol. Her husband, Leonard, supported her through those first difficult weeks. They walked together every morning. He ate regular meals while she had her shakes, never making her feel left out. Within 3 weeks, Gloria's fasting blood sugar was in the normal range. By 8 weeks, her A1C had dropped to 6%. Her doctor discontinued the Metformin entirely. That was 3 years ago. Last month, Gloria's granddaughter got married. Gloria danced at that wedding. She felt strong. She felt present. She wasn't exhausted by afternoon. She wasn't worried about her feet tingling on the dance floor. Her diabetes isn't cured. She knows that. If she regains significant weight, those cycles could start spinning again. But for now, at 69 years old, Gloria is in remission. Her locks are clear. Her insulin works. Her blood sugar is normal. And she did it by understanding what was really wrong and working with her doctor to fix it. If you're a Pure Longevity VIP member, you'll receive a printable checklist summarizing everything I've covered today, the questions to ask your doctor, the warning signs that you're a good candidate, the safety precautions to take. You can literally hand it to your healthcare provider at your next appointment. If you're not a member yet, the link is in the description below. Now I want to leave you with something important. For decades, the medical establishment told people with type 2 diabetes that their condition was inevitably progressive, that beta cell function would decline year after year, that they'd eventually need insulin injections, that this was just how the disease worked. Taylor's research has shattered that paradigm. Type 2 diabetes is not inevitably progressive. The beta cells are not dying. They're not dead. They're drowning. They're suffocating under fat that doesn't belong there. And when you remove that fat, many of them can recover. This study demonstrates that beta cell ability to recover long-term function persists after diagnosis, changing the previous paradigm of irreversible loss of beta cell function in type 2 diabetes. That's not my opinion. That's from Cell Metabolism, 2018. You are not broken. Your body is not failing you. Your cells are blocked. The locks are jammed. And now you know what's jamming them. Comment taking action if you're going to bring this to your doctor. Comment already knew if you'd heard about this research before. And comment need more if you want me to do a follow-up video diving deeper into the specific protocols. If someone you love is struggling with blood sugar that won't come down, if they're feeling hopeless, feeling like their body has betrayed them, please share this video with them. Because this information could change everything for them. Subscribe if you haven't already. Hit that notification bell, because I'm going to keep bringing you the evidence that can actually change your health outcomes. And if this video gave you genuine value, if it shifted how you think about your condition, consider using super thanks below. It highlights your comment so my team can prioritize responding to your specific questions. Remember, you didn't fail at controlling your blood sugar. You were fighting the wrong enemy. Now you know what the real enemy is. Now you know it can be cleared. And now you have the roadmap to take to your doctor. The locks don't have to stay jammed. I'm Dr. Elizabeth Blackwell. Thank you for trusting me with your health. I'll see you in the next video.